So this talk is the malignant soft tissue tumors, also known as soft tissue sarcomas. What we'll do in this talk is kind of outline some basic definitions and general treatment recommendations, I suppose, for soft tissue sarcomas in general. Then go through some specific subtypes where the treatment doesn't matter, or it matters, but where the treatment doesn't vary that much between treatment types, but on tests, the presentation and mainly the histology is different, which they can ask you. And then what I've done at the very end, which there won't be any audio for, is attach a huge file. Basically, for those who have been to the review course before, it's just correlates between radiology and pathology of all tumors, so not just soft tissue sarcomas, but benign bone tumors, malignant bone tumors, and basically it just goes through the somewhat classic radiographic and pathologic presentation of various things that come up on tests, so it can be used as a review for you. Again, there's no audio to it, it's too long, and I didn't get Dr. Hoda to help me with it. We can do it in the future, but anyway, so that's there for your review on your own. You can forward through the slides at your convenience or study stuff that you feel you need to. So anyway, back to malignant soft tissue tumors. By definition, a soft tissue sarcoma is a malignant tumor of mesenchymal tissue. They have a varying degree of local aggression and potential to metastasize, which primarily is due or associated with the grade of the tumor. So that's a test question. What's the most important sign of potential for metastasis? And other than metastasis itself, it's the grade, the histologic grade of the tumor is the answer to that. As I kind of mentioned, there are many histologic subtypes, but in general, the extent of surgery, and for that matter, the extent of treatment, depends on the histological grade and obviously the local anatomy, where the tumor is located, the juxtaposition or lack thereof of neurovascular structures also obviously has implications for surgery. Radiation treatment, which the acronym is XRT, is also used for local control and helps us when we do have close margins to allow limb-sparing surgery to have equivalent rates to that of amputation because we can use radiation to help with local microscopic control. In general, soft tissue sarcoma, the workup, usually these present as, for the most part, painless masses, leads to x-rays, but the test of choice is an MRI of the lesion. Once you have a diagnosis of soft tissue sarcoma, the workup in terms of evaluating for metastatic disease historically would consist of a CT of the chest, because sarcomas kill patients, remember, by metastasizing hematogenously to the lungs, so a CT of the chest, and then a bone scan to look for the rare or uncommon situation of a bony metastasis, which does occur, but much, much less frequently than metastasis to the chest. And I'll talk about PET scanning. That's obviously you've heard about PET scanning, you've probably even seen it. It's becoming more and more in vogue. The standard of care in most places now is kind of replacing the CT of the chest and bone scan. It's a test all in one that we'll talk about briefly. I use it, and I think most places use it, and I've seen it coming up on your tests now. The principles of biopsy should be discussed. Biopsy can be done in a variety of different ways. One is just with a needle, also known as a fine needle aspiration. It's commonly done for lymph nodes and, say, breast masses. It's very safe. Can be done under CT or ultrasound guidance. The only issue with it, obviously, it's just a small needle, so you get really no tissue, you just get cells. So there's a big sampling error, and you need a very good cytopathologist to evaluate those cells for the potential for malignancy. True cut biopsies, people can do in the office just under a local anesthesia for palpable masses that are of concern. Obviously here you get a core of tissue. It's basically you core out a small piece of tissue with a larger needle, but again, it can be done just with a small, little tiny stab incision. So you get more tissue than an FNA, but still they're the same issue. More tissue, but still not a lot of tissue, so there is the sampling error. The next, I guess, step up would be an open biopsy, incisional biopsy. This has to generally be done in the operating room, so there's a morbidity, time, and cost associated with that, but you do get more tissue, which of course the pathologists like in terms of making a more definitive diagnosis. And then the concept of excisional biopsies is generally done for things that are known or for very small superficial masses. We talked about in the last talk about superficial subcutaneous lipomas, so something that's known, that's very small, that's superficial, that even in the off chance that it turned out to be something malignant could be easily re-excised. You can, it'd be reasonable to perform a marginal excisional biopsy of those type situations. Biopsy technique, questions on this come up because it's important, because done improperly can have significant implications for patients. So biopsies, if you're going to perform an open biopsy, and this is true whether for soft tissue or for bone, you want to think about where you're putting the biopsy and how you're doing it. So in general, you want to put a biopsy in a longitudinal, what you would envision as a longitudinal incision line and an extensile line, something, an approach that you can make a very large incision to resect a mass. So in general, you want to avoid neurovascular structures. Unlike most of what we do in surgery or in orthopedic surgery, where you want the intracompartmental exposures, through nice internervous planes. The opposite is true for biopsy techniques. The concept being that you just want to contaminate one compartment, so one muscular compartment, rather than spreading potential malignant tissue up and down internervous planes. So biopsies are done intracompartmentally. And then, it seems a little silly to say, but meticulous hemostasis, obviously important for surgery in general, but even more attention paid for it in biopsies, because what you don't want is a large hematoma, potentially full of malignant cells that then contaminates surrounding tissue and needs more aggressive or wider surgery. Kind of mentioned this already, but the workup for a soft tissue sarcoma, most people that come into my office already have an MRI, but if you see somebody with a suspicious lump or bump, MRI clearly is the test of choice. For masses that are known to be soft tissue sarcomas, the workup for metastatic disease is a CT of the chest or a PET scan, should put in here. PET. This new PowerPoint is very cool. One other exception to this is where you would obtain a CT of the abdomen is for lower extremity myxoid liposarcomas. This is just something you have to memorize or know. It's myxoid liposarcoma, we'll talk about a little bit towards the end of this, is a variant of liposarcoma common in the lower extremity, and for whatever reason, it has the potential to spread to the retroperitoneum. So CT of the abdomen for myxoid liposarcoma is indicated in a workup. For children who have rhabdomyosarcoma, these are thought to be tumors of embryonal origin. So these kids get bone marrow aspirations to look for cells on the bone marrow, because that changes chemotherapy approaches. So again, that's strict memorization. Rhabdomyosarcoma kids need bone marrow aspirations. Then most of you know that there are a few soft tissue sarcomas that escape the rule, that do spread via the lymphatic system. Again, remember, most sarcomas spread hematogenously and therefore spread to the chest, but there are this subset that, again, for reasons that are unclear, spread like breast or prostate carcinomas and can spread via the lymphatic system. Amy Wasterlin came up with the acronym SCARE. There are other acronyms, but basically it's just memorization of the subtypes that can spread to the lymph nodes, which, again, it's an easy test question to ask. I won't read them out for you. You can read and memorize them on your own. The whole concept of lymph node metastasis, again, it's unusual, but I guess not rare. They say about 10% of the sarcomas will spread to the lymph nodes. Again, the majority just spread to the lungs and skip lymphatic chains. That being said, there's no known benefit to routine lymph node dissections like historically was done before sentinel node biopsy in the breast and prostate cancer treatment. However, when you're evaluating those specific subtypes, the scare subtypes that do have a known tendency to spread to the lymph nodes, you do have to evaluate the lymph nodes, whether that is with sentinel node biopsy or with a PET scan. Is up to the treating surgeon. That's not a test question, but what would be a potential test question is that those lymph node does need to be evaluated because it can have implications for treatment. This slide is just an example of a MRI of a soft tissue sarcoma. Try to burn this into your brain. This happened to be a myxoid liposarcoma, which there's no way you can tell that simply based off MRI, but it shows you the principles of what a soft tissue sarcoma looks like on MRI. One is that there are the ones that we deal with primarily are deep. That means they're underneath the fascia, they're in the muscle, or deep to fascia. They're not subcutaneous. They're large. That's number two. They're large, which by definition is 5 centimeters. Why 5 centimeters? Again, there's no science behind it. I mean, there's logic behind it that the bigger something is, the more potential it is to be something bad. But 5 centimeters is our magic cutoff. That's number two. Number three is that they're heterogeneous on MRI, so you have this kind of mixed appearance, these very dark areas, more gray areas, really light areas, and that is because there are different subtypes or different cell types going on biologically. There's tissue necrosis going on in the center, so you get this heterogeneous appearance on the MRI. It's not uniform like you would see in a lipoma. And the one that sometimes trips people up is that in general, as a general rule, soft tissue sarcomas are well encapsulated. You see here it has this nice defined capsule, which is kind of counterintuitive. Patients ask, and medical students, residents ask, well, these should look kind of infiltrative. And although microscopically, sure, there are potential microscopic cells in here. That's why we'll talk about chemotherapy, radiation, and wide surgery. When you look at it on MRI, you can't appreciate that, and what looks like a very well encapsulated process. I've mentioned PET scanning, so just a little background on it. Probably people know more, or certainly a lot of people know more about it than me, but those listening, you may even have heard more about this in medical school, but it's basically a quantitative analysis, so unlike a bone scan or even an MRI, where things are somewhat relative, the PET scan gives you a quantitative analysis. It gives you something called the SUV, or standard uptake value, which basically gives you an idea of the tissue activity, which is calculated very mathematically, and it's well documented statistically, basically where you see the activity of the tissue based on the amount of radionucleotide that's injected into the patients. The bottom line is you get this SUV that gives you an idea of the metabolic activity of the tumor, and that's important in terms of monitoring treatment, monitoring recurrence, monitoring for metastatic disease. It's quantitative, so again, it's a mathematical thing. So an SUV in New York City would be equivalent to an SUV in Seattle. So it's not like you're comparing a qualitative analysis like a bone scan where you say something's hot or has uptake. This gives you more of a solid objective data point. Here again is that same example of the myxoid liposarcoma I showed you with the MRI, but what the PET scan shows is areas that are active. So in this case, the superior pole of the tumor, much more active on the PET than this inferior pole where the tissue was more necrotic. So this, if you had this PET scan prior to a biopsy, it could help you plan a biopsy. It would also potentially has implications for resection where you might be more aggressive or less aggressive. That's the interesting part of the PET scan. This is an old slide, but I like it. Again, this is something I did back in the day. So I did a needle biopsy of 3 different areas of this same myxoid liposarcoma. And the point is the areas that was very hot up here had this very high grade histology. This area down here that had very low uptake on the PET when I did a needle biopsy down there, all you saw was necrotic tissue. So this is the power of a PET. It can help you in treatment, diagnosis, etc. Here again, this is just an example of a patient we treated with a PET prior to treatment, showing very high SUV. They got chemotherapy, radiation treatments prior to surgical resection, and you can see that the SUV significantly improved. And at the time of resection, the mass was very necrotic, which obviously has good prognostic signs for the patient. This is somewhat of a busy but important slide because it goes over the general treatment recommendations for soft tissue sarcoma. Again, these are just generalizations. In reality, obviously, multiple factors come into consideration when considering treatment. So, again, these are generalizations, but they kind of help as a springboard in terms of where to start when thinking about treatment, whether it be in the real world or on a test. So, superficial masses usually are, I've mentioned before, those small little subcutaneous masses that are mobile. If they do turn out to be something malignant, generally they're low grade, which is obviously good. Usually these are just treated with surgery alone because you can be pretty aggressive with skin lesions, get wide margins, and if you can't primarily close it, it's usually pretty easy to do a local simple flap or a skin graft to easily cover the defect. Deep lesions are a little bit different though. Usually these are the larger lesions. Usually large, deep, heterogeneous lesions are more high grade, which obviously means they're more problematic in terms of potential for metastatic disease. So these get added adjuvant treatments besides surgery. So not only do they get wide resection, but in general, to try to help with local control, you use radiation treatment. Radiation can be given preoperatively or postoperatively. In general, most places try to give it preoperatively because you can give lower doses. It's thought to potentially have a little bit better tumor control, but what you do sacrifice with pre-op radiation is that the normal skin is then radiated, is burned essentially, so they have higher healing complications than if you give post-op radiation. Chemotherapy becoming more and more accepted at larger institutions. There's not a ton of scientific data to support it, except in rhabdomyosarcoma in kids and synovial sarcoma in adults. Those are two sarcomas that there's definitive evidence that chemotherapy is of benefit for these patients. I won't go into the nuances and numbers. They're not going to ask you that, but they potentially would ask. Certainly a child with a rhabdomyosarcoma, part of the treatment besides surgery and radiation for local control is chemotherapy. Same with synovial sarcoma, which usually affects younger adults. Principles for limb-sparing surgery. We don't really talk about this anywhere else in these tumor talks, so I'll just kind of throw it in here. And this is true for bone and soft tissue malignancies. So the principles of limb-sparing surgery is clearly you need to preserve somewhat of a functional limb. I mean, it's probably not going to be a normal limb like it once was, but you need to have some reasonable amount of expected function afterwards to make it a reasonable undertaking. Cosmesis also potential consideration for some, but really the most important thing is you need to have a functional limb at the end. Makes sense that if the tumor is in an area where you're not going to be able to get a negative margin for whatever reason because of involvement of neurovascular structures or contamination of a joint, that would be a contraindication to limb-sparing surgery. And I just mentioned this in general, the tumor can't encircle, can't circumference the neurovascular structures. That would be a relative contraindication to limb-sparing surgery and an indication for an amputation. The concept of margins also comes up on tests. It's just the definition again, defining what different types of margins are. Obviously for malignancies, you want to get a wider margin, which means you're dissecting through a band of normal tissue. So if this is a malignancy, I talk about cutting the tumor out in a box. This myxoid liposarcoma, you would plan a surgery, something like this, where you take a rim of normal tissue on each side to get a negative margin. An intracapsular margin would be a procedure where you actually operate inside the tumor. So an example of that, more commonly than a sarcoma, would be like a ganglion cyst in the hand, where you puncture the cyst wall and spill the ganglion contents. That's an intracapsular margin. A marginal margin is what we do for like lipomas. Like say this was a lipoma where you just shell out the lesion. So you just kind of go right around the capsule, right around the margin. That's a marginal margin. Again, so you would be leaving behind potential microscopic cells that you would take out with a wide resection, which is what we do for malignancies. What do you do in a positive postoperative margin? And what is a good margin? No one really knows. I mean, it depends again on multiple factors, what the diagnosis is. The grade of the tumor, obviously very important in terms of its potential to spread or regrow, size, location, all important factors. So we really don't know what a good margin is, and I'm not sure we ever will. What we do know is that people that have a positive postoperative margin, so if you were to perform a resection of this and the pathologist says there's microscopic cells, growing up to your margin, in general, again, these are general rules, the recommendation would be a re-excision to try to take out more of that tissue. That said, these are sometimes blind re-excisions. It's not very gratifying, but that would be the principle on a test. If you have a positive postoperative margin, unless they're steering you in another direction, the answer would be that you should re-resect it and definitely consider radiation treatments to try to control local disease in these areas that might have even defied your re-resection. Chemotherapy, yes, for rhabdo and synovial sarcoma. If they asked you to choose it on a test for primary treatment, I guess I would say no, but I don't think they would ask that. Again, it's too much of a controversy, and there is a trend now for more use of chemotherapy in the treatment of soft tissue sarcomas. The unplanned OOPS procedure. So what happens, what do you do if you see a mass that's removed that was expected to be benign? This usually happens more in these small subcutaneous superficial masses that are taken out by dermatologists or in the office by usually general surgeons or something that then don't know how to really treat a sarcoma. These lesions where they're just kind of shelled out in the office or surgery center, there was a low index of suspicion by definition. The thought is that the mass is benign, and therefore you're going to leave behind microscopic disease, and therefore there are high local recurrence rates. So basically, if there is an unplanned excision of what turns out to be a soft tissue sarcoma, the recommendation is to re-excise that for the same reason we talked about on the last slide, to remove any micrometastatic disease that's in the tissue. Usually you have to remove more tissue than if you knew it was malignant. That's why a high index of suspicion is important if you're evaluating lumps and bumps. Even re-excisions can have positive margins. Oftentimes that's because we think that when a mass is removed intracapsularly or intralesionally, a lot of the tissue can get contaminated, spread around in the local area, so it's not unusual to get even a positive margin on a re-excision. And again, the principle here is that if there's a suspicious lump or bump and you're not sure how to treat it or you're not sure what it is, it's probably better to refer it than it is to guess and treat it. What I'm going to do here is go through some of the more common soft tissue sarcomas that come up on tests. As a general group, these are all relatively rare, but they all present in a somewhat similar fashion. There is subtle differences sometimes in terms of the age and the location, but in general they present as painless masses, and the treatment, again, is not usually tailored for any one specific soft tissue sarcoma, again, other than the exception of the rhabdomyosarcoma or synovial sarcoma, and also keep in mind those that can metastasize to the lymph nodes. But these are the ones that show up on tests. Usually it's a histologic question, basically, is what I'm getting at. So I'm going to go through some of the more common ones, certainly not exhaustive, complete review of every single soft tissue sarcoma out there. That's a near impossible task. So MPNSTs, known as malignant peripheral nerve sheath tumors, usually these are soft tissue sarcomas in a little bit older individuals. Obviously, by the name, they're going to involve some sort of peripheral nerve. Doesn't have to be a named major peripheral nerve. Could be a smaller nerve. These are sporadic, except in the case of neurofibromatosis, which we talked about in the last talk. So again, anybody with a history of neurofibromatosis that has a rapidly growing known neurofibroma or a painful neurofibroma should raise a red flag in terms of concern for malignant degeneration. These are going to stain for S100 positive, and again, the treatment in general for all soft tissue sarcoma is always going to involve for a wide excision, surgical excision, and radiation treatments. These happen to be very aggressive with poor 5-year survival. This is what they look like under the microscope. Can look relatively bland, although it's pretty hypercellular. You see these kind of vesicular spindle cells going through that looks kind of nervous. Looks very similar to the neurofibroma that I showed you in the last talk, which again is why the presentation and stains are important here, though you see kind of odd looking, very dense nucleoli. You see multiple on this lower power, you see multiple of those, multiple malignant looking cells. So again, in the right situation, clinically you would be concerned about a malignant peripheral nerve sheath tumor. Here's an example of a rhabdomyosarcoma that I've mentioned here a few times in a child. So this is the most common soft tissue sarcoma in a pediatric patient. They present anywhere 40% of the time in the extremity, which means 60% of the time not in the extremity. Head and neck is common. The ENT physicians see it as well in the head and neck rhabdomyosarcoma. Workup I've mentioned already, MRI of the lesion, bone scan or CT scan of the chest to look for metastases, or a PET now. But remember, these rhabdomyosarcoma is thought to be of embryonal origin, so these kids get bone marrow aspirations. And remember, this is one of those that defies the general sarcoma, soft tissue sarcoma rules and can metastasize to lymph nodes, so they need attention to the sentinel node. This is rhabdomyosarcoma, fits into that category of small round blue cell tumors, which is what it looked like under the microscope. So even if you showed experienced pathologists this slide, they'd say, yeah, it's a lot of small round blue cells. You know, this could be potentially lymphoma, myeloma, Ewing sarcoma. I mean, it's all over the map. Obviously, treatment of all those is very different. So again, you have to correlate the clinical findings to the pathologic pictures, which is why special stains and cytogenetics become important. So rhabdomyosarcoma has a characteristic T213 translocation. So that's a cytogenetic translocation that can be marked and helps in differentiating that from other tumors. They stain for muscle markers, so desmin and myogenin. The treatment I've mentioned now a few times, chemotherapy is part of it in these kids. They have good 5-year survivals because of the use of chemo. Another example, leiomyosarcoma, again, another smooth muscle, or this is a smooth muscle tumor, so it stains for the smooth muscle markers. There's no cytogenetic treatment. It can look very bland. Again, depending on the presentation and where you are, this could look like a lot of different things, which is why it's a diagnosis of exclusion, and you need to use these special stains in terms of defining a diagnosis. I've mentioned this one before, synovial sarcoma. It's a little different, usually because it presents oftentimes in adolescents and young adults, unlike typical soft tissue sarcoma is in an older individual. These, for unknown reasons, happened in younger patients, usually not children, but young adults, adolescents. They often present with a small painless mass that can be present for years, so this kind of goes against the general thought that soft tissue sarcomas are rapidly growing, fast-growing malignancies. Although it's synovial sarcoma has a large or a high risk of metastatic disease. It can be, again, present kind of indolently, kind of a slow-growing mass. This is one where you can see calcifications on a plain X-ray. I don't think I have an example of that here, but here's a skeletally immature patient where you see this calcified mass on the MRI, you see these punctate calcifications, which you would see on an X-ray. And despite the name, and even though I show an example here right next to the knee, it's a kind of a fallacy. It's just historical. The reason they originally were thought to involve joints in the synovium, but that's actually not true. You can find these tumors anywhere. So they do not necessarily involve the synovium. You can find them in the middle of the quadricep, for example. They do not have to be around the joint. It's just a nomenclature thing. So remember that. They don't have, the name can kind of fool you. They have two forms, so they love this on the test. They love this biphasic form here because it is kind of a classic appearance. It kind of almost looks like a carcinoma, almost glandular. You get these very cellular, like columnar-like areas with it mixed with this like amorphous material inside of it. This is a biphasic synovial sarcoma. There's also the monophasic form shown over here, which admittedly doesn't look that much different than leiomyosarcoma, which is why you can't tell the difference on a simple H&E slide, which is why that we resort to the translocations again cytogenetically to make the diagnosis. So synovial sarcoma, unfortunately, it's just memorization, has the X18 translocation that leads to this protein gene transcript, the SY2, SSX1 or 2. Huge minutia point, but I've seen it on a test. The SX2 mutation or a protein has a better prognosis for reasons that are unclear to me. And again, remember, this one's a little bit different in terms of the treatment. These are young adults. There is data to support the use of chemotherapy in the treatment of synovial sarcoma. Fibrosarcoma, again, I mentioned it because it has histologically a very similar appearance to some of the things that we've been seeing. It too, like leiomyosarcoma, is a definite diagnosis of exclusion, but unlike a leiomyosarcoma, fibrosarcoma would not stain for muscle markers. Sometimes pathologists talk about this herringbone pattern, so the herringbone, like a herringbone suit, where you get this kind of cross-hatched appearance of the cells. They do have this characteristic ring chromosome and the 1217 translocation. Again, just strict memorization. You can make a list and cram it the week or a few days before your test. Treatment in adults is surgical resection and radiation. In kids, they'll try a chemo. But again, it's kind of a diagnosis of exclusion. This slide's important because this probably identifies the most common soft tissue sarcoma, which is a pleomorphic sarcoma. It used to be called an MFH, malignant fibrous histiocytoma. So if you go back and review old tests, that's what you'll see. In today's world, the pathologists try to be a little bit more descriptive of it and just calling it a pleomorphic sarcoma. Sometimes you'll see it also called just a high-grade sarcoma, NOS, not otherwise specified. These, again, usually older patients present as a painless mass. And what you see histologically shown here is just this bizarre background of highly malignant cells. You see these bizarre, highly mitotic cells, but there's no identifiable cell origin. So what you don't see is fat, muscle, nor can you stain for muscle. You don't see nerve, nor can you stain for nerve. They do all the translocations, and they don't find any known translocations. They can see very bizarre translocations, but no known one that's consistent, say, with like X18 and synovial sarcoma. So this is kind of again a diagnosis of exclusion. These are high grade. There's no clear role for chemotherapy except maybe in recurrent or large cases. They're not going to ask that on the test. The treatment is wide resection and radiation treatments. Another favorite on tests, although very rare, is because it has a unique histology, is clear cell sarcoma. These, for unknown reasons, often present in the distal extremity in a young adult. So this is the most common malignancy to see, or is a common malignancy, not the most common, is a common malignancy to see in the hand. Can be associated with tendons. This is one that can spread to the lymph nodes, so remember that in terms of workup. The reason, again, I think they like it, besides its unique kind of presentation in the extremity, in the hand and distal extremities, is that it has this central nucleolus with this very clear cytoplasm, hence the name clear cell sarcoma. It too has a characteristic translocation, which unfortunately just have to memorize if you want to nail that question on the test. Other than the histology and the translocation, the treatment no different than the other ones that I have mentioned. Epithelioid sarcoma, again, rare, but one that comes up on test. This is because it is the most common hand sarcoma. It affects young adults just like clear cell sarcoma. The difference here is that unlike a clear cell where you have the central nucleus and the clear cytoplasm, what you see are these individual epithelial like spindle cells with the background of dense collagen stroma. So you don't see that in clear cell sarcoma. The cells are quite plump. You can say it looks clear, but what you don't see is the central nucleus that you see with a clear cell sarcoma. Again, remember this is part of the scare. These are ones that can spread to the lymph nodes, so remember that in your workup. However, the treatment no different than that what we've mentioned before. Chemo reserved for recurrent or late cases. In general, it's a surgical disease treated with surgery and radiation. Liposarcoma is a very common subtype of soft tissue sarcoma. It's the most common adult soft tissue sarcoma when taken as a group. I mentioned that pleomorphic sarcoma is the most common, which is true in terms of numbers, but liposarcoma, when you lump them all together as a group with the various subtypes that I'll mentioned, is the most common. Presents as a painless mass, and here are the different subtypes, which they have asked on a test. So lumped all together, these are the most common soft tissue sarcoma in adults. It's well differentiated is because of that, which is basically just a large atypical lipoma that has some atypical features, up to a dedifferentiated, very high-grade liposarcoma, and I'll show you some quick examples of these. So this is a well-differentiated liposarcoma. Mentioned it in the benign talk. It basically presents just like a lipoma, but what you don't see in a lipoma that you do see in a well-differentiated liposarcoma are these lipoblasts. So what you see are this indented nucleoli with this indented vacuole basically in the nucleoli. They will stain for S100. They have, although they're considered malignant, they have very low metastatic potential. They do have a tendency to recur locally, which is why sometimes we will follow these patients much closer than we would for just a lipoma without any atypical features. I don't think they'd ask you treatment on a test. I treat them just like a lipoma and follow them clinically. Some people treat them with wide excisions like you would for a malignancy. Obviously that has morbidity, so for recurrent cases I'll consider that, but the point, I think the take-home teaching point is that well-differentiated liposarcoma is a tumor with a tendency towards local recurrence, not so much a tendency for metastasis. Contrast that to a dedifferentiated liposarcoma, which basically here you see this this line of dedifferentiation. What you see down here in the bottom is what, if you just had this slide down here, that almost just looks like a typical lipoma where you see a bunch of adipocytes of fat cells. But what you see here is this area of dedifferentiation, this sharp line demarcating between what looks pretty low grade to something that, if you zoom in, looks very high grade. So you see these multiple mitotic figures. So this is a fatty tumor that's dedifferentiating. So it looks relatively low grade to benign here, dedifferentiates to high grade in this side. Treatment, chemo, not on a test. Wide resection and XRT, yes. Prognosis, again, not so great. They're not going to ask you that on the test. Prognosis for all these soft tissue sarcomas, just as for your understanding of 50% at 5 years is what I kind of quote people, but again, that's kind of lumping everything together. It's not stuff they're going to ask you on a board test. Here's just an example of the dedifferentiated liposarcoma. So what you see down here is an area of dedifferentiation. Here the tumor looks somewhat more fatty, well-defined. Here you see a center of necrosis, but here is the area that actually dedifferentiated from the fat. So you see this almost looks like normal fat, but this is the area that looked very high grade, and that corresponds to this area where here looks like normal fat and here it becomes high grade. This is that same MRI of the myxoid liposarcoma. the point I put this in here is to show that different depending on where you are on the PET scan or even on the MRI, the necrotic areas are going to have a different appearance on the MRI than potentially the higher grade areas. This is why the MRI looks heterogeneous. Myxoid round cell liposarcoma is kind of an intermediate to high grade sarcoma. So it's not dedifferentiated, but it has this little lipoblast looking cell as well as this myxoid background where you have this kind of purplish, bluish, grayish background consistent with extracellular matrix, hyaluronic acid. It has characteristic translocations. Remember, myxoid liposarcoma in that lower extremity can spread to the retroperitoneum, so you need to consider, or not consider, you need to obtain CTs of the abdomens to look at those. Translocation leads to TLS CHOP protein, which has research implications, but also more importantly for you is it has diagnostic implications in terms of pinpointing the diagnosis. Treatment, similar to everything, chemo maybe for refractory or metastatic cases, but wide resection or radiation treatment. Pleomorphic liposarcoma, another high-grade liposarcoma, where you see still some fatty cells, adipocytes, but obviously a background of very malignant, ugly-looking, pleomorphic, atypical cells, no translocations. But again, if you see fat in the background, that would indicate that you know the cell type of origin, so you should be thinking the liposarcoma family. And this is true of anything. If you didn't see fat, but perhaps you saw muscle or nerve, then that would send you down a different path in terms of making a diagnosis, which is the troubling kind of torture part for you in terms of making the diagnosis. And the reason it's torture is because the treatment's still the same. The treatment is wide resection and radiation treatments for high-grade tumors. So that's kind of a brief run-through of the more common sarcomas that come up on tests. What I've thrown in here is 900 slides. It's huge. I call it pathologic correlates to radiographic correlates. I think Leon Ryback from radiology, we made this, or he really helped put together this talk a number of years ago now. Not a lot has changed. But you can go through, take your time, kind of thumb through the slides. There's no audio to it. And this includes most every pathology, radiology that you're going to see that you could see on a test. It includes very rare things, more common things, includes bone, soft tissue, benign, malignant. Again, you can study the things that you don't know. If there's questions, always email or give me a call. We can go through it. I'm not going to spend hours going through everything. You can do that on your own. Concentrate your studies on what's important to you or what you feel weak in. So that's the end of malignant soft tissue tumor talk. Again, feel free to reach out to me if there are questions about any of these things or of these next 800 plus slides. Thank you for your time.